You're listening to The Pelvic Messenger, hosted by Dr. Amy Stein and Dr. Corey Hazama. Presented by Beyond Basics Physical Therapy.
Hi, I'm Dr. Amy Stein, pelvic floor physical therapist and founder of Beyond Basics Physical Therapy in New York City, and author of Heal Pelvic Pain and Beating in Endo, How to Reclaim Your Life from Endometriosis. Today, we're chatting with Dr. Jose Eugenio about the endometriosis journey, a comprehensive resource from diagnosis to treatment. And for those that don't know the famous Dr. Eugenio, can you tell us a little bit about yourself and your journey and how you got involved in endometriosis?
So my name is Dr. Eugenio, and I got involved in endometriosis after I had a patient in Rhode Island. It's a long, dark story, which we're not going to really go into it in detail, but I had a patient with endometriosis when I was a general OBGYN back in Rhode Island. And I operated on her. I could, to the best of my abilities at the time as a general OBGYN. I sent her to oncology. Oncology saw her, offered her hysterectomy, take out her ovaries and everything. She was only 24, 25 at the time. And then she came back and kind of accused me of not wanting to operate. She tried to hurt herself. Thankfully, she did not succeed. And then that's when I realized that general OBGYNs are really never trained in how to treat patients with complex endometriosis. So I did fellowship in minimally invasive surgery. And while I did my fellowship in minimally invasive surgery, I wanted to get a lot better at doing endometriosis surgery. I did a rotation at the Center of Endometriosis Care in Atlanta, Dr. Sonervo. After that, I went back. I wanted to stay in the end of the world because before I saw him, I never saw other surgeons that treated endometriosis in the same way that he does, like treating it like it's a cancer. So removing it of wherever you see in any little corner, any little small spots of endometriosis have to be removed at the time of surgery. Even though we know that there's no cure for endo, but the closer we can get her to not having a single spot of endometriosis in her pelvis, the better it is in the long term. So I wanted to stay in the endometriosis world, and I went to St. Louis University at his recommendation with somebody that he had trained before, which is his name is Dr. Patrick Young in St. Louis. And then Patrick Young went private, and I became the director of the Center of Endometriosis in St. Louis. And after a while, I decided to come back down to Rio de Atlanta to be a little closer home to the Dominican Republic.
Very nice, very nice. And how did you end up specializing like right away in excision surgery, or how did that come about? Because I know you mentioned a lot of like fellowship and training. How did that come about?
So the problem with fellowships in endometriosis or in minimally invasive GYN surgery is that not all fellowships are alike, right? So American Association of GYN Laparoscopy, AAGL, has their fellowship in minimally invasive surgery in multiple universities and non-university hospitals around the country. It depends on which hospital do you go, depend on who is the person training you. You will be exposed to much more or less endometriosis. Like, to put it in context, I think the year I graduated residency in 2011. I went back for fellowship in 2015, finished in 2017. So the year I graduated from fellowship in 2017, I think we did an internal polling with me and some of my classmates, and the average amount of endometriosis surgery that people did was no more than 20. And that is in dedicated surgery, surgical centers dedicated specialty in minimally invasive surgery. And for my own experience at that time when I did my fellowship for the first year and a half of fellowship, I don't think I did over 30 surgeries with endometriosis or complex endometriosis, right? But in a month here, I did 35 surgeries in 1 month during my fellowship when I did this rotation. So after 2 months, I've done over 60 surgeries for endometriosis. And after I finished my fellowship, I actually requested and begged Dr. Smerver to see if I could stay longer and continue learning on endometriosis, and because I like the way that he approaches it. But more than liking the way that he approached it, what I fell in love with the results that he was getting with patients, which is something that I didn't see, because in the time that I've never seen in my career as an OBGYN in the United States. Like, I saw patients that had a year, 2 years, 5, 10 years after surgery that came back after their childbearing years have been completed and they wanted a hysterectomy. And essentially people that had 20, 30 specimens of endometriosis in their first surgery and had 1 to no specimens of endometriosis 10, 12 years later. So, I mean, even though there's no cure, we did multiple surgeries of patients in which we're doing hysterectomies after they've completed having kids, and we didn't find any endo, right?
Yeah.
So I've never, ever seen that. So, and we looked. It's not like, well, we're repeating the surgery. No. We removed a lot of specimens, and none of that stuff came back as endometriosis. And the second surgery, so I'm like, this is onto something. And then when I went to St. Louis, I basically forbade anything related to obstetrics and just focused 100% in an endometriosis practice, which Dr. Patrick Young had continued to develop in St. Louis after leaving here. He was there for 10 years, so it's really easy to me to just stay in the same goal or in the same field, which is, I think, what needs to happen. It needs to be totally separate from regular MIGS. It has to be specialty endometriosis practice. And for me, it was easy because when I went to St. Louis, we already had a colorectal surgeon. We already had a cardiothoracic surgeon to do some diaphragmatic cases. So, and we had a urology team that would see, gynecological urology team that would already know about painful bladder syndrome, plus a whole slew of specialized sonographers for complex endometriosis scans. So I've been very lucky in that sense. I didn't have to build anything. I came in, the system was already implemented. I just have to thrive. So it was really good for
Yeah, that's similar to pelvic floor physical therapy, just the training. You can't get it in PT school. And then even outside of PT school, it's like it's so varied. Which is makes it very similar in the sense that like you can go to an endo specialist and you could do really well with someone like you. You could go to another quote unquote specialist and not have as much success. So physical therapy, as you know very well, is similar in that it depends a lot upon the training. Can you tell me a little bit about why there would be all those specialists in the room at the same time, just or on calls if in case you needed them? Can you tell me us a little bit about that?
Well, the problem is that a lot of the times when I saw a patient before doing fellowship that had complex endometriosis surgery, or they attempted to have complex endo surgery, it was always the same story. Like, a patient gets taken to the operating room and then somebody says, we did not know it's going to be this difficult, or we had no idea it was going to be like that. And at that time, I took it for their word. I'm like, well, man, we didn't know, right? But then now, knowing what I know, it's not that there's no reason to be surprised when you take a patient to the operating room for endometriosis, because there's a lot of things that you could do, right? But the main issue is that training and the people that you have around you have to be knowledgeable to the disease so that you're minimizing the amount of surgeries that the patients get. Like, let's say that, for example, yesterday we were doing a really, really complex diaphragmatic endometriosis case where a patient has had multiple lung collapses that started after she did IVF. So she has complex endometriosis. She couldn't get pregnant. She had big endometriomas. They stimulated her anyway. And then she ended up having a lung collapse after she got stimulated, right? Because all that endometriosis in the endometriomas had been there for a while. She had the lung collapse in which they put a chest tube and managed it like that. And then we took her back to the operating room, but everything was stuck together. So we have to be able to take her back, knowing what's happening, and at the same time, plan for other surgeons to be there. Because we knew that we needed to work on her diaphragm. We knew that we needed to probably work on her lungs. So, right, so you have to have a cardiothoracic surgeon. So this patient even had endometriosis on top of her heart, on the pericardium, which is the sac that's actually covering the heart. So it has to be a group of doctors that are very knowledgeable about the disease and that have been like treating this for a while, right? So it's easy for me to be doing a really complex case. I know that the bowel needs to be resected, so I'll just call the bowel surgeon and say, hey, we have one today. This is happening, and then so okay, cool. I'll be available at whatever time. Let's work. So they already know what's going to happen, right? And if we have to call a urologist in the middle of the case, hey, we need to reimplant this ureter, or we need to fix this. There's a big group of doctors that we can just call, and having that is just phenomenal for the patient because it minimizes the risk of complications significantly, right?
Yeah.
And then also it minimizes the need for repeat surgeries, which is one of the things that happens. Like, because when patients were taken to the operating room and they go, oh, we did a diagnostic laparoscopy, we did not know it's going to be this bad. Now you're going to have to be set to somebody else to do another procedure, and then that person has to have more people. So that why not send them to a specialist from the beginning, so that the patients can have one surgery where everything is done after they've been properly evaluated, and there's no surprises, you see?
Yep. And why do you recommend, like, a patient like this, what in from your experience of working with physical therapists, why is it important to have the physical therapist do prehab and post-hab
So the
for a
most
patient
important
like
part
this?
about this is that a lot of the times patients get surprised that we send them, or I want them to start doing for physical therapy even before surgery. And they're like, but I haven't had surgery yet. I'm like, no, you're not understanding. The tricks and the tips that they'll give you, the way that they'll talk to you about breathing, abdominal breathing, diaphragmatic breathing, pelvic motion, the way that they can teach you how to contract or relax your pelvis. All those things are not after surgery. They're additive to the surgery. They'll help us understand what's happening to your pelvic floor, and then what is happening with your pain. Is the pain more downwards or upwards? How is your pelvic floor impacting your overall quality of life and pain? And then after surgery, patients are very surprised when they see that they have a significant improvement in their quality of their pelvic floor. But sometimes if you just send them after surgery, they don't have that evaluation before, then they don't know what's truly going on or if it's actually working, right? So that's one of the important things about sending patients to go to pelvic floor physical therapy before to do. And in some cases, some patients may even need to do, at the time of surgery, pelvic floor trigger point injections. You may need to do blocks of the cervical obturator or pudendal nerves, right? So all these things need to happen sometimes before surgery, because it helps us identify a lot better what are the things that we need to change after surgery, or how can we focus on the things that need to change after surgery. Because it's important for them to understand that surgery is not the only option for pain control, right? A lot of the times, even after surgery. So one of the things that we're big on is it's actually, the patient has to understand that when we do surgery, they're going to be my patient forever. It's like, it doesn't matter if I go to anywhere, Dominican, Uganda, France, Mexico, it doesn't matter. They're always going to be my patients. So I'm always available for my patients to talk or have a conversation to know what's happening, right? And one of the things that I tell them after surgery that they need to monitor is bowel, bladder, pelvic floor, and sex. And other types of pain, like depending if they have diaphragmatic or umbilical or bowel or other issues that we need to focus on. But the beauty about this is that when we follow them prospectively for a very long time, we can tell how things are working. We can tell if it's more a bowel issue, if it's more a bladder issue, if it's more pelvic floor, or if it's a cyst or something. It's something that we have to make sure that they understand that it's not surgery and you're done. And then you're more in pain. I don't know, I did surgery, I'm good, just go somewhere else. No. Like, we don't dismiss patients. We want to make sure patients understand that forever, whenever they want to see us, I usually schedule them. Let's say that we do a random surgery for endometriosis. We'll do a visit 1 to 2 weeks after surgery, 8 weeks after surgery, 6 months after surgery, and a year after surgery through telemedicine. For example, I talked to a patient that actually had a year after surgery. She's doing great, right? She's doing great. She's having only pain. Bowel is perfect. Bladder is resolved. Periods, she's taking 1 ibuprofen in the whole 4 or 5 days of her cycle, which is unheard of for her. but she's still having a little bit of issue on pain on insertion during sex, right? So that is something that once we identify it early, then she understands, like, the pain that I'm having is not endo pain, it's pelvic floor pain. Because that's the beauty about having patients understand this before. It's easy for them to, like, oh, no. This pain that I'm feeling on this side is endo. This pain I'm feeling on that side, it's actually more pelvic floor. But if they never go to pelvic floor physical therapy before surgery, it's way harder for them to do.
They won't, yeah. They
I don't
won't
know
understand.
what's your opinion on this?
Well, on that one, that patient that you just mentioned, I'm like, right away, I'm like, superficial transverse perineum muscle, deep transverse perineum muscle. Someone's got to get on that external perineal body and on the like the layer one of the pelvic floor. Those are
Yeah,
usually the culprits for pain with insertion. But
yeah,
yeah, I find the same thing. I find that dialing down the pain prior to surgery, they have better outcomes with the surgery. So helping to get rid of the trigger points, if there's gripping in the abdominal wall, if the diaphragm's not even moving because of the endo or because of guarding, because they're guarding because of all the pain and discomfort, and they're not breathing properly, like they're using like
true.
all chest breathing and they're not expanding their
Not
diaphragm.
exactly,
So
yeah. So
yeah.
it's funny you would say that, but because it's a lot of the times after they come in and they do the prehab, like they're like, oh, I didn't realize I was doing all this,
Yeah.
right? And it's because nobody talks to them in their general GYN practice talks to them about, like, what are the benefits of this? And it's not only for endo. There's a lot of different conditions that patients that may not even have endo can actually, like, having prehab or pelvic floor therapy can contribute to their overall well-being,
Yeah.
right? So it's very important, but also it's important on who you go to, because it's just like you said. For example, when I was in St. Louis, we had a big team of physical therapists, and some of them had to, like, they worked with other physical therapists that were only focusing on pelvic floor internal and external work, right? Not all physical therapists are the same, just the same that not all gynecologists are the same. Or not all GYN surgeons or not all endometriosis surgeons are the same, right? So that's the importance of working and having that direct feedback with our PT team. Like, I send you a patient and you're like, hey, she's doing well. And every couple of months or a couple of weeks, you get, like, I get a report back and they say, okay, this is what happened. This is where we work at. And then this is how she's improving, right? And sometimes if they hit a wall, then, okay, look, you're hitting a wall for this. She's finding that, like, the transverse perineal is really, you're having significant issues, or in the ischio or vulval muscles, you're having some issues. Let's go in and, like, let's do a trigger point injection, localized, right? And we can go into a trigger point injection. Sometimes we can. I had a patient recently that we took back after she hit a wall in PT, and we took back and when I did the sonogram and the exam, I identified her uterosacral as being part of the culprit. So we just did a block, and we injected 10 cc's in each uterosacral. And she called back a week later that she was like, I did not know that regular people would poop like this.
So,
Right, and it sounds funny that somebody tells you that, like, they're happy that you just sit and you poop and you don't have to do anything.
right,
No,
right.
no tips and tricks, no breathing, no legs. You just sit, poop, right? Because that titanic contraction of her uterosacral and pelvic floor caused her to have significant pain. Because a lot of
Yeah.
times it's important for them to understand that sometimes that contraction that they're doing without really noticing that they're doing, it's a defense mechanism. But over time, that defense mechanism turns against the patient. So it's how learning how to relax those areas. Right. This is not the time to tell patients, like, oh, you have to do 4 Kegels, because that's not going to end well.
Right. Have you ever had patients that they do like the prehab and then they don't have to go through surgery?
Yeah,
Or
yeah, that happens too, because the only indication for surgery is pain.
right.
Right. So sometimes you have patients that, like, that are a year or 2 years out of surgery and they have pain. And I was like, okay, we evaluate them. I'm like, we don't think, I don't let, before we take you to surgery, let's just be a devil's advocate and just trust me on this, but let's have you go to a pelvic floor PT and let's give it a month. And they give it a month and they come back constipated, but never have any pain. But congratulations, I cured her without having to do surgery. Right.
Yeah.
So Yeah, so it's important that patients get evaluated um, for this. And I mean, one of the things that I had um, that I did a lot before, it's a little harder now because we have a lot of patients coming from all over the world, um, from literally all over the continent we've operated. I think the CZ has operated patients from over 70 different countries. In last month, I'm probably going to say that we've operated people from 6 different countries.
Wow.
Dubai, Canada, Mexico, Dominican Republic, France, just in like a month, right? So sometimes I wish that some of our international patients could like see or benefit from seeing some of our PT team, from people in our PT team, but it's a little hard for them because they come in for the surgery, but so then becomes harder for us to like manage that portion of their care.
Yeah.
But we sometimes what we do is before we try to get them here a day or two before their surgery so that they can go see PT and then get that get that feeling of what are the things that are working or not working afterwards.
Yeah. Yeah, we get we get quite a bit of patients from out of town too, and we try to at least see them for like the 3 to 4 days, but it would be hard to see them like right after surgery. So yeah, that makes sense. But so let's go back to the basics. So what is the correct definition of endometriosis these days? Because it has changed, as we know, over the decades.
So it has changed. It's going to continue to change. I don't think we're going to end up with a magical definition that everybody's going to be happy about, right? So the current definition right now is like it's endometrioid-like tissue that has estrogen progesterone receptors. And in some occasions, you may have tissue that is endometriosis, but may have aberrant estrogen progesterone receptors that either may not respond to medications or may self-stimulate. But the problem with this tissue, if you go back to the basics, and this is the analogy that I tell most of my patients is this. What happens, Amy, when you cut your skin? You bleed. Bleeding causes a clot, right? That clot causes a scab, and with the scab falls off, you have skin, right? And what's the second thing that happens when you cut yourself? Your body has to protect itself because every time you cut yourself, the body has to think, okay, I got a cut in my hand. Something from the outside is going to come in and try to invade our body because it broke our defenses, right? So what could that something be? It could be a parasite, a virus, a fungus, or a bacteria. So whenever your body cuts itself anywhere, it has to do what? It has to call in the white blood cells to go and surround that specific area to cause what? Inflammation. So that inflammation are these white blood cells surrounding this area and liberating a lot of inflammatory cytokines that are going to cause swelling, redness, pain, right? And that hypersensitivity in this location. So that is called the inflammatory process. So in endometriosis, this endometrioid-like tissue that's found outside of the uterus, depending on where it is, it can cause very different pathologies. If you have endometriosis tissue on top of the bladder, you can cause an inflammation of the muscle of the bladder or the tissue, and if it's big enough, it can actually penetrate into the bladder, causing patients to have hematuria. You can also have patients that have endometriosis on the nerves that go to the bladder, which can cause the patients to have significant bladder spasms, or bladder dysfunction. Or if the nerves are totally damaged, you can have patients that have significant urinary retention or dysfunctional urination just because of really affecting the nerves or because of the pelvic floor issues that can actually affect the bladder in a negative fashion. So these cells could also be where on top of your intestines, which could be large or small intestine. These cells that are there monthly, as your ovaries are producing hormones, right? The two hormones that the ovary produces in its majority, which is estrogen and progesterone, estrogen causes a stimulation of these cells that are outside of the uterus to grow. But the issue is that these cells that are constantly growing and multiplying can cause formations of new blood vessels that could bleed. They can cause formation of aberrant nerves, right? Or right. So new nerves are growing or in this tissue that can actually make everything in where they're growing send abnormal signals to the brain regarding pain, right? So this can cause new blood vessels to grow and new nerve endings that can cause pain. But more importantly, when they bleed, guess what happens? You have chronic inflammation of the area where they're touching. So if it's on top of the ureter or on top of the nerves, they're pushing on your pelvic sidewall, they're on top of your intestines. In fact, we've had so many patients that are told that they have IBS, right? They have that switch between constipation and diarrhea with their periods all the time. But only happens with their periods, happens mostly with their periods. And they've got colonoscopies and EGDs and motility studies and a whole bunch of stuff. And we don't know what it is. It's probably IBS, right? We do the surgery. They find they have endometriosis in their large and small intestine, and they're known to have significant issues.
What would you, on that note, like what are some, so you explained bladder, bowel, you explained diaphragm before. What would be some of the causes of sexual dysfunction or sexual pain?
So it's important for us when we're educating patients or asking questions about endometriosis. One of the things that we talked about is about sexual pain. So sexual pain is divided in two mainly, right? So it's pain on insertion and pain deep inside. So we separate the pelvic floor from pain with deep penetration. Pain with deep penetration can be associated usually to more disease at the level of the uterosacral ligaments or nodules of endometriosis between the rectum and the vagina or behind the cervix, or the connection or joint or abnormal junction between the cervix and the intestine, right? So that's very separate. So it's important for them to make that distinction. And some patients have pain on both or none or one or the other, right? So that's important. So when we are doing an evaluation of the pelvic floor to the patient, we basically give them a picture so that they can see what are the muscles of the pelvic floor, right? We talk about the global, the ischios, the superficial, the deep. We talk about the obturator and turnus muscle. All these muscles in the pelvic floor that contribute to the overall health, the lineator ani. So they need to know what is it. And one of the things that we do in order for them to start differentiating one muscle group from another is that when we do an exam in the office, guess what we do not use?
A speculum.
A speculum. We do not use a speculum. And patients are like, oh, you're not going to use a speculum? I'm like, no. I want to make sure that I'm examining your pelvic floor in its entirety without using a speculum. So we need to basically do a digital exam of each one of these muscles. And I asked them to give me a number from 1 to 10 of how much pain do they have when I touch these muscles individually, right? Starting from the outside of the vulva and vagina, right? We look for the clitoral reflex. We look for the anal wake. We look for all these things that can actually tell us what's happening with the pelvic floor of the patient, right? We look for tone. We look for being able to relax it, to what happens to the pelvic, because it's a dynamic organ. It's a dynamic muscle group. So you want to make sure that you're examining it under different tension, right? We use a Q-tip test on the outside to see if they feel the same way on the right side to the left side of the vulva. If they have any differentiation in their muscles in their legs. Do they have any weaknesses in their legs, right? Because that can tell me if there's any deeper endometriosis all the way down to like their sciatic nerve, right? We touch the labia separately with Q-tips to see if they feel the same, if they can feel the difference between something that's sharp or pointy and something that's dull. Right? Patients are like, oh, wait, I don't feel that on that side. Well, then that's something that we have to explore, right? So that's when we start introducing what? The dermatomes. We start introducing the dermatomes. So I had it here printed with me, but I don't have it at the moment. I think I left it at one of the patient's offices. But we literally show them the vulvar dermatome so that they can see, and we give it to them, hey, like, depending on what her signs and symptoms are. Like, I want you to take this with you. And your next period, I want you to start marking with an X, very specific where the pain is. Is it at the groin? Is it the labia? Is it besides the clitoris? It's under? Is it more towards your butt? Is it like, so because if they don't know where the pain is, we can't find it.
Right.
So one of the best predictors of how good the surgery is going to be is if the patient can actually localize her pain. It's different. She says, I have pain here, that I have pain over here.
Yes.
Right? So that's important. So that's why we try to be as specific as possible. And I know some patients are like, well, nobody's ever asked me so many questions. I'm like, okay, I don't know about that, but I just wanted to get to the bottom of where the pain is.
Right.
Because the worst thing that can happen is that I do surgery and then your pain has not even changed. Right? So that is horrible. So that's why we're asking patients so many questions. so that we understand and we can localize where the pain is. Because when we can localize and we can touch it, we can improve it significantly.
Yes. Agreed. And do you find that, for listeners, do you find that um like birth control pill or IUD, that can be helpful enough so that a patient doesn't have to have surgery, or do you feel that surgery is always like
No, so
needed?
surgery is not always the answer. Surgery is not always the answer, but and we talk to patients a lot about their signs and symptoms, right? So the only reason to do surgery is if the patient has pain. So one of the things we got a lot of, or I got a lot of criticism about before, was that my rate of finding endometriosis was over 90%. So because if I find endo, and it's documented like by the amount of like surgeries that I did and how many patients had a positive result of pathology, right? So we got into some conversations with some of my colleagues before in the university settings, and they're like, well, if you're finding so much endo, right, when you operate on patients, it's not that all the patients have endometriosis that you see. I was like, no, they don't. But the reason is that I want to make sure that whoever I take to the operating room has a very high likelihood of having endometriosis. The last thing I want to is to put a patient to the financial strain of surgery or the risk of surgery and not finding endometriosis. And even though it's really low, less than 10% of the patients that we operate don't have endo, they may have something abnormal still, either fibroids or adenomyosis or pelvic adhesive disease, but they may not have endometriosis, right? So it's important for us to be very judicious in who do we take to the operating room, because we don't want to expose people to risk of complications. So to answer your questions, one of the things that we don't do is we also don't mask the disease, right? We can tell patients, hey, listen, if you're having pain, depending on the evaluation or the patient's goal, we could consider, why don't you start birth control for a couple of months to see if it works? If she is okay starting birth control, right? Or why don't you start doing some lifestyle changes, doing PT, doing exercises, doing some things that can improve your overall quality of life. And if your pain disappears, then we don't have to do anything. We can just monitor you long term like that. You're having pain? No, pain will sex disappear. I just take a birth control. Like as long as they have to understand that the fact that birth control or other medications removes your pain doesn't necessarily mean that they don't have endometriosis. It means that if they're not in pain, they don't need to have surgery. Right? So it's a different thing. It's not that they're cured or they don't have any endo, because studies have already proven that. There's a beautiful study that was done a while ago. It talks about divided approximately 50-50 patients, right? 50 patients for one group, 50 patients for the other group. So the first group were patients that had pelvic pain and some issues suspected to be endometriosis, were giving birth control, and while they took the birth control, their pain improved, right? And then the other group was a group of patients that had suspicions for endometriosis, were still giving birth control, and their pain did not improve. So you have 50 patients that their pain improved, 50 patients that their pain did not improve with birth control, but they had the same symptoms throughout before taking birth control, right? Now, what happened? They were all taken to the operating room, right? 60+% of the patients in one group, like 68% of the patients in the groups that their pain did not improve with birth control had endo. And like 65% in the group that their pain did improve with birth control had endo. So what does that tell you? That the positive or negative result on birth control has nothing to do with the patient has endometriosis or not. So what I tell patients is the reason we find such a high number of patients is that it's like playing the lottery with a cheating hand. So there's a couple of questions that when you ask the patient, are you having this, X, Y, and Z? If they have this, any family history, they have over a 70% chance of having endometriosis at the time of surgery, right? So then it's like, if you had a 70% chance of winning the lottery, you'd probably play more often, right? So that's what we do. It's just a numbers game. We're talking to the patient. We're inquiring, did you go to PT? Did it help? Did it not help? It did help, but I'm still having this pain that is different. Or now I can differentiate what's pelvic floor pain from what's internal pain or abdominal or pelvic or side pain, right? So that's the importance of having patients to go to PT before surgery.
Right. And what is considered an accurate diagnosis of endo now?
So a lot of people are talking, there's a lot of conversations right now, for example, about giving patients like drugs that have significant side effects, right? And I don't want to point fingers or say names of drugs not to be canceled or anything. Not that I really care that much, but there's a lot of doctors specific, and lately I've found that a couple of people that are dedicated themselves to like remove endometriosis are studying our patients on these GnRH agonist antagonist medications that have significant side effects. And if their pain disappears, then okay, fine, I'm not doing surgery. But they have all the symptoms, and then the patients come back, and we see them like after been taking these medications for a year or two, they stop the medication and their pain is right back to where it was before, right? Or worse, I have patients that are given medications and they're taken to surgery while they're taking the medication that's supposed to hide the disease, which does not make, which in my mind is bananas, right? You're going to suppress the patient, suppress her cycles, have her not have any periods, and then you're going to look for a disease that it's suppressed with the medications that you're giving. So you're going to miss a whole bunch of early lesions, right? So that doesn't make any sense to me.
And what other conditions are mistaken for endometriosis? I know you said obviously pelvic floor can be contributed to the pain, and that can mimic symptoms of endometriosis and painful bladder syndrome. What other ones?
So one of the things that I tell the patients is that when we're talking about pelvic pain, we have to divide the pelvis or causes of chronic pain in 5 different categories, right? So category number 1, gastroenterology, Crohn's disease, ulcerative colitis, inflammatory bowel syndrome, small intestinal bacterial overgrowth, chronic constipation, chronic diarrhea. 5 quick things just from your GI tract that can give you chronic pelvic pain. Then we go to urological causes. You can have urethral diverticulums. You can have bladder spasm because of interstitial cystitis. You can have if you have gastric nerve lesions that could be affected by endometriosis. You can have endometriosis of the bladder, right? You can have ulcers in your bladder that can cause significant issues with pelvic pain. Then we go to gynecological causes of pelvic pain, right? Which are fibroids, adenomyosis, endometriosis, pelvic inflammatory disease, because of sexually transmitted diseases, abnormal cyst, endometrial polyps, cervical polyps, cervical cancer, uterine cancers, only from the gynecological portion of it, right? After that, you have pelvic, chronic pelvic, you have musculoskeletal causes, right? Pelvic floor. It could be vaginismus, it could be vulvodynia, it could be pelvic floor dysfunction. It can be because of having dysfunctional or dyssynergic defecation, dyssynergic urination. So you can have a lot of different things. It can be something affecting the obturator nerve, the pudendal nerve, right? It could be all these other things that can cause significant pain to the patient. And then we have chronic pelvic pain syndromes, right? You have like, and the example that I usually tell my patients is like, if you have a soldier that goes off to war and they step on a landmine and they blow their foot off, they have significant pain in that foot that was amputated above the knee after the landmine went off, right? So that pain, that they don't have that foot anymore, but they have pain and they feel like that there's something grabbing onto that toe and causing significant pain. So that could be a neurological cause of pain, right? So, which can cause like central desensitization because the nerves that were going to that specific location are just sending abnormal impulses to the brain relating to, hey, there's a turtle biting my toe, despite the fact that I don't have a toe, right? So it could be many different things.
Yeah, we see that quite a bit too, where a lot of the musculoskeletal system gets significantly improved, but they still have those abnormal pain syndromes like the phantom limb syndrome, where they're still feeling the pain in the area, but yet the musculoskeletal is improved. And that's where the pain science come in, and the importance of educating on pain science and trying to down regulate the system, and as you know, do like mindfulness practices and trying to calm things down.
Yeah.
And it could be extremely effective for these patients. But yeah, it's definitely complex. And uh, you guys are definitely the experts in this area. So we appreciate all you do and everything you do for your patients.
Well,
I
thank
do have I do have some more questions if we had a little bit more time. So how does endometriosis affect reproductive health and fertility?
Oh, that's a good question. So, endometriosis affects fertility in multiple different ways. So, we're talking about infertility. We have to evaluate how does fertility happen in the first place, right? So, we talk about the patient. We talk to the patient about how does the sperm get to the egg, right? So, once after intercourse, the sperm goes into the vagina and gets sucked into the uterus, and it's supposed to travel when it's into the uterus outside of the fallopian tubes to cover the both ovaries and sperm for a couple of days, right? Sperm lasts in the abdomen, covering the ovaries a couple of days, waiting for patients to do what? To ovulate. So when ovulation happens, a cyst, right? The function of the ovary is to create a cyst, and inside of the cyst, they have an egg. When I tell patients what the function of the ovary is, 90% of them can't tell me because it's something that sometimes it gets forgotten or it's not taught really well. But the function of the ovary it's very simple. It's to create a cyst. And inside of that cyst, I have an egg. And as that egg is growing, it's producing what? Estrogen. So that estrogen goes inside of the uterus and makes the inner lining of the uterus, endo, inside, meteor, matrix. One of the jokes that I tell often to my patients is that we Latinos call the uterus the matrix, right? Útero o matriz, right? So the inner lining of the uterus is endo, inside, meteor, matrix. And the muscle or the covering of the uterus is myo, muscle, meteor, matrix. So the muscle of the matrix and the inner lining of the matrix. So the estrogen goes to the inner lining of the matrix and makes what happens. It has little tentacles grow into the lining of the matrix so that and these tentacles are like Velcro. And their function is to do one thing, and it's to latch onto the placenta. So when the cyst breaks and ovulation happens, the egg gets together with the sperm at the level of the ovary and the fallopian tube, or the entry of the fallopian tube. But we ask them a very simple question. If you have sex today and you do a pregnancy test tomorrow, it's going to be positive or negative? It's going to be negative. What about the day after you have sex or 2 days after you have sex? It's still going to be negative. Why? Because pregnancy happens at the end of the fallopian tube, but when the baby grows inside of the uterus. So when that happens, that baby has to travel from the fallopian tube or the bigger opening of the fallopian tube close to the ovary. It has to then travel all the way inside of the uterus where it's going to implant itself and seed itself inside. So that is the regular process that has to happen for a woman to get pregnant, right? Now, how does endometriosis affect this? Number one, remember the example I was telling you about how endometriosis how when you bleed from your hand, you can have inflammation? So the same thing endometriosis does inside of your pelvis. So if it's the top of the ovary, on top of the fallopian tube, behind the uterus, behind the ovary, on top of the bladder, that can cause a massive amount of inflammatory fluid to build in this location. So sperm is alkaline, right? So if you have alkaline sperm coming into the body and you have alkaline sperm dumping into a pool of acid, it's going to die. So that's one way, right? What's another way? The sperm lasts usually around 2 to 3 days inside of a woman's abdomen, right? In that posterior uterine pouch, just waiting for ovulation to occur. But the egg only lasts once the women ovulate, the egg only lasts for 23 hours and 59 minutes because the egg is precious, right? It's only one, so it's really, really precious. So that egg is just waiting there to be fertilized by the sperm. But if you drop the egg in a pool of acid, right? So that's another reason why the egg can actually have an issue. But let's say that the egg did survive the pool of acid and the sperm did survive the pool of acid. Now you have an embryo that's developing inside of a pool of acid, and that embryo has to then travel back to the uterus. If the scar tissue that happens to the fallopian tube, right, causes that fallopian tube to be small enough to the sperm to go through, but the embryo is quite big, so when it's coming back, it can get trapped inside of the fallopian tube, causing a ectopic pregnancy. Right? So that's a way that endometriosis can affect pregnancy. And that's another way. It can also completely obstruct the fallopian tube, right? And when that happens, you have inflammatory fluid building inside of the fallopian tube that would not allow sperm to get in, but also would not allow the egg to be picked up. So in that case, that fallopian tube that can cause a massive accumulation or a hydrosalpinx or hematosalpinx, which is a fallopian tube full of blood or water. That water that's being produced, some of it because of pressure, gets dumped inside of the uterus. So if the other fallopian tube was open and then you were able to get pregnant and now you have a baby inside of the uterus, that other fallopian tube that's blocked, because it's usually blocked in the outside end, not the inside end. So that fluid that's being produced, it's known to be cytotoxic. So that fluid is a baby killer, right? So when women get pregnant and they have a blocked fallopian tube, they have a super high chance of having a miscarriage or abortion, because now you're trying to grow a baby inside of a uterus that's surrounded by inflammation and by abnormal immune response that can actually hurt the baby, which is why women with endometriosis have an increased risk of miscarriages or abortions.
Right.
So there's many different ways that endometriosis can negatively affect the growth of or the possibility of pregnancy.
Right. And is that why for some, like the surgery is an indication to help them? Like how would surgery help with that patient population?
So what happens is that, number one, what we usually try to do is give the patients the possibility, if they can, to get pregnant naturally, right? Not only once, but multiple times if they want throughout their life. So what our approach is, we want to go inside. So we know that endometriosis is one of the biggest causes of infertility in the world, if not the biggest, right? So there's data that talks about like the possibility of, you have a patient that has infertility, and the definition of infertility, what is the definition of infertility? Is having a woman have sex for a whole year, less than 35 years old, giving it the good old college try for a whole year, and not being able to get pregnant, right? So if she has that definition, if she meets the definition of infertility before 35 years old, because if it's over 35, it's only for 6 months. But if you meet the definition of infertility, and you have really beautiful, I have a period and I'm at the beach with my friends and I just realized I just got my period today because I started spotting that. So meaning that you're one of those lucky women that has, not lucky because that's normal, right? So you're one of those women that have a really normal period with like not even taking Tylenol or ibuprofen or nothing. You're just use a pad or a tampon and you go about your life, and your periods don't change your things that you do at all, and you have infertility. The possibility of that infertility being caused by endometriosis is 50%, up to 50%. But if you have infertility, but on top of that, you are part of the group of women that a couple of days before your period, it's like, a hurricane is coming, right? The Weather Channel already told you that it's going to be raining. So you know that it's going to happen a couple of days before it does. You start planning your life around your period. Oh wait, I have a meeting. Maybe I can push the meeting for the following week or do it sooner. Or I have some job thing or some party or some wedding. I'm planning everything around my cycle. And you have severe pain with your cycle. You have painful with pain with deep penetration, pain with bowel movements, and pain with defecation and urination and horrible periods, then the possibility of that endometriosis being the cause of your infertility, if you're this type of woman, could be up to 87%. So with or without painful periods, endometriosis is extremely high possibility of patients having infertility. In fact, a lot of our patients continue to get pregnant many, many years after surgery naturally. Because what we want to do is want to remove what's causing the infertility in these patients, which is actually the endometriosis. So you go inside and remove the disease and use membranes and barriers and different tips and tricks that we already developed for a while in order to improve their quality of life, but also to minimize adhesion formation or scar tissue formation, so that so their fallopian tube works phenomenally and their ovaries are not having big endometriomas. we're able to get patients pregnant naturally. And in the off chance that we still can't do that because we had to cut out her fallopian tubes, then we send them to infertility treatment. But after we've done surgery, because our approach is different. We've seen, like the example that I told you before, that when patients that have severe endometriosis get infertility treatments, their endometriosis becomes way, way worse. So yes, we're bypassing the reason for their infertility, but what happens later? What happens if they get pregnant? Phenomenal. And if they get pregnant, but then after the pregnancy, that we have to see the repercussions of endometriosis embedded into the vagina, right? Because in order for them to remove it, to get the eggs, they have to basically put a needle through the vagina, go into the ovary and harvest the eggs. But that same technique can actually cause endometriosis to be implanted besides the cervix at the level of the vagina, which we see here all the time. And then we have to remove a part of the vagina. The uterus can be compromised. We're seeing lots of patients here that have lost a kidney because they have these nodules besides, at 3 and 9, besides the cervix, or at the level of the uterosacral that's expanding laterally and it's taking the ureter, and the patient just lost her kidney. Or like the patient that I talked to earlier that after an infertility procedure, or after an IVF, and she collapsed the lung because of all the endometriosis, and she developed an endometrioma inside of the chest and another endometrioma on top of the liver. Right. So she lost, I want to say yesterday, she lost over 45% of her diaphragm. It was just infected and a part of the lung with endometriosis. So these are the things that we need to be cognizant of.
Right. Yeah, we really appreciate working with you guys side by side and helping these patients, because it is so rewarding. And on top of that, when we're working together and helping these patients with fertility and pregnancy, it's super rewarding, because obviously the PTs, the pelvic floor, can contribute to the pain with sexual activity, abdominal pain, and all the above. So I know we both find working with our patients extremely rewarding. Challenging, but rewarding. So tell us the difference between excision and ablation surgery, because I think a lot of people understand the difference more now than they used to, but I still feel like there's a big void with understanding the differences.
Okay, so let's see. How do we simplify this? So imagine a garden, right? Imagine having a garden, and you tend your garden, you love it, you plant beautiful plants all over it, and you love your bushes and your roses and everything, right? But between these beautiful plants that you carefully tailored, you have some weeds. And these weeds continue to grow, and they're very aggressive, right? But in order for you to remove these weeds, what you're doing is actively burning the surface, what's above the surface, right? So you burn what's above the surface, but there's a limit of how much you can burn above the surface. But why? Because it's besides, or it's really close to things that are very precious and beautiful to you. Ablation, the same thing happens. You see a lesion of endometriosis on the pelvic sidewall. You see a lesion of endometriosis on top of the ureter, on top of the nerves, on top of the intestine. And what you do is you very quickly use energy or something to burn, to tap the surface of something, right? But the problem is that only chars the surface. But endometriosis is not a surface lesion, it's an iceberg. So what you see is usually the tip of the iceberg, and that's where the problem lies. Why? Because when endometriosis is digging inside, it's going around really dangerous structures, which is the same reason that when patients get taken to the operating room, they only burn the surface, right? Because they're afraid to burn deep inside. So now, if somebody throws a piece of hot coal at you, for example, and you swat it away, you may feel the heat in your palm, but your hand may not get burnt. Why? Because in order to transfer the energy, you need two things. You need temperature and pressure and time, present, three things. So you need to actually apply the heat under time and pressure so that the heat can distribute itself evenly and going deep into the tissue. But the problem is that deep into the tissue, you have five things that are very important and very dangerous, which are nerves, arteries, veins, ureters, and intestines. So you don't want to just burn indiscriminately in these things because you can have massive complications. So they just burn the surface and the lesions or the roots of the lesions stay behind. So what we do is called excision surgery. So what we figure out is where is the disease? And I'm good to go, and I'm going to start removing around the disease. Like it's a cancer. So if this is my disease, I'm going to basically create a halo around it. And I'm going to cut on the clean side of it so I can surround it and dig and approach the bottom of the disease so I can remove the whole thing and the roots, even if it's on top of the bladder, even if it's on top of artery, veins, nerves, or the intestines, or if it's on top of the ureters. Why? Because I know that once I open these spaces, I have to be very aggressive. Because if I'm not, then the endometriosis, if it comes back, it's going to go deeper. So it's an example that a lot of times tells the patients, like if you have a house and you go into a house or you're buying a house and there's a room and the room has mold on the drywall, right? If you just burn the outside of the drywall, the mold is actually penetrating into the studs or deeper where the studs are located. So you can't burn the surface. You have to remove all the drywall. But what's the issue now? That now all the studs, all the wiring behind the wall are exposed. So that means that you have to be very aggressive because if you're not, when endo comes back, it's going to go back where? Into the studs. We're talking about the pelvis. Now you have endo that's like closer to the sciatic nerve, right? Like on top of the inferior gastric plexus. Like it's digging towards the obturator nerve, right? So towards all these nerve structures or vascular structures that can make repeat surgery significantly more difficult. So that's the number one reason. You have to go and try to make sure that your first surgery is excision surgery. And one of the things that we have to start talking to patients about now is that I was thinking about like figuring out a way to have patients understand their pathology. Not like, oh, they removed 3 spots of endometriosis and it came back positive in pathology. Yeah. But look at your pictures. You have the whole sidewall is littered with endometriosis, right, from surgery. And then what corresponds to that sidewall? Oh, left sidewall, and then look at pathology, left sidewall. So your sidewall has a couple of centimeters of tissue, right, that is affected with endometriosis. And the pathology says that you had 0.5 centimeters of tissue sent to pathology. That's positive for endo. So what does that tell you? That not everything was removed from the site. So it's very simple. I've seen patients that are told, oh, I remove your endometriosis. And then specimen sent to pathology. It's bananas.
Yeah.
Right? Oh yeah, I'm an endosurgeon. I remove your endometriosis, and how many specimens I sent to pathology? None. So how was that done? How did you remove something if nothing goes to the lab? I don't think it's legal to cut an organ or a piece of a patient and just throw it away and not send it to the lab.
Right.
Right? I mean, that this doesn't happen in cancer surgery.
Right.
Would you imagine that you have cancer and somebody takes you to the operating room and they would, oh, you have something on the inside that looks like cancer? I burned it off. But you don't have it anymore. But wait. So what type of cancer? Like, what's the issue? Like, where was it? What's the location? Oh, I burned it.
Right.
It's the same thing. So this doesn't happen to cancer, so why does it happen to it?
Right.
I don't get it.
Yeah, I agree. So we both know that the Endo Summit, which we both have spoken at, I think that's where we met. So
Yeah.
which has been wonderful over the years. That's a great resource for patients, and it gives them a lot of more appropriate information rather than misinformation. What are other resources for patients for finding the appropriate information on how to treat and take care of endo?
So the endo summary is a really good one for patients and practitioners to go and meet, so that so that you get to talk to a lot of people. You get to also hear new ideas, how they're treating endo over here, what is their experience and what are their results. So that makes you good. Like it improves your quality as a surgeon, as a human, right? And the other spot that I usually tell patients to go at is actually Nancy's Endometriosis Education on Facebook. I tell everybody that comes into the practice, like, hey, you'd like to go, I would recommend them to go online, go to Facebook, there's support groups. The disclaimer that I tell them about the Nook is that this is not a place that you're going to go to, like, I have a headache. Is this endometriosis? They're not going to accept that, right? This is a place for you to go to get educated on your own time. And it's like homework, and you are required to do the reading. You are required to invest the time and effort to gain the knowledge so that you understand your disease, so that number one, you're not bamboozled, and number two, it's extremely difficult, if not impossible, to gaslight you anymore. Right? Because it's hard to have somebody make you question your own sanity when you've documented and you know what's happening to your body, you know what's happening to your pelvic floor, right? When you know about the dermatomes, you can map out where in your leg the trajectory of the pain, right? You can tell if it's S1, S2, S3, if it's a combination, if it's the right leg, the left leg. No, no, no. So that it helps you understand the importance of having a really good, solid document about your pain. And a timeline, which is something that I require a lot of my patients to have. Just give me a pain calendar. Like, how often are you having this spasm in your vagina or in your bladder? Or how often are you having pain in the leg? Where is all the pain in your period? Oh, in my leg. Okay. You measured it in passing and you don't have a physician that's going to dive into that seemingly unseemingly important term that you just said, oh, I have some cramping in my leg. No, no, no. Like, what is it? You lose weakness. Is it numbness? Is it tingling? Is it the right side? Is it the inner thigh, outer thigh? Like, all these things are important to know. So I think they can go to the note, get information. There is really good websites. Our website has a lot of information on endometriosis. There's and then very different other pelvic medicine websites that have a plethora of information on pelvic floor. There's a lot of good influencers online that are just putting a ton of content regarding endometriosis.
Right. Yeah. Yeah, it's definitely important to find the appropriate sites, as you mentioned, because you and I have both had patients that have gone down rabbit holes with the misinformation and on different Facebook groups and websites that don't have the correct information. So really finding your resources and making sure they are legitimate and really up to date is really important. So I do want to end on a positive note in that I would like to talk about some recommended lifestyle changes that you suggest to patients, and then I'll just chime in for our patient population.
So it's what lifestyle changes all implies that they know exactly where their pain is. So the number one thing that I need to know is like, or I need them to understand is what are the things that are causing them pain. So it's not like, oh, you got pain over here. No, I need them to give it a name, a last name, a nickname to their pain. Because if they can identify it, we can work on it individually. Because one patient can have a lot of bladder issues, but at the same time have endo, or a lot of bowel issues at the same time have endo. And they can have pelvic floor dysfunction or vaginismus or vulvodynia. So it's very interchangeable. So it's like the way I think a lot of doctors fail in treating patients with endometriosis because they feel, well, I mean, I did your surgery, there's no more endo, go away, or it's not my problem, or you want me to do another surgery, and then we can go inside. And then if they find or don't find anything, well, I don't think in the pain after the second surgery also does not improve, right? So that's the importance about having them understand what are the things that are happening? What are the things that are giving them pain so that we can work on them individually, right? So that's the first thing. Second thing is I usually, which is paradoxical to patients, right? Like, I know that you're in pain, but I want you to have an active lifestyle. What does this mean? I want you to consider doing yoga, Pilates, or something that's going to basically help you improve your core. But also, I want them to do that once they also know what's the state of their pelvic floor. Okay? I want them to know, because I don't want somebody that has a really tetanic contraction of the pelvic floor to start doing certain yoga poses or certain Pilates exercises that are going to make them actually contract the pelvic floor even more. So it's identifying what are the things that are causing them pain so that we can work around them, right? It's very important for them to keep a pain calendar, right? The pain calendar gives me information. I can see in 30 days where were the things that were giving her pain. But more importantly, I ask them, if you have pain on X, Y, and Z, I want you to annotate what you have for food and drink for the last 2 days. Because a lot of the times you're able to identify, hey, I had a pizza. And every time I have a pizza, like, and they don't have to write everything that they eat. But if they have pain today, what did you eat yesterday? And sometimes you're able to catch it. Oh, yesterday I had a pizza, or yesterday I had a glass of wine, so that you know, like, oh, every time I have this, for the next 2 days I have a little bit more pelvic floor discomfort. So that's the importance of having the calendar, right? Or have a lot more bladder spasms because of this. And when I have a lot of bladder spasms, then that triggers me to contract my pelvic floor a lot more, which can now trigger a flare up of pain, right? So these are some of the things that we talked to them about, like lifestyle changes that can help them. I usually tell my patients that during sex, like we have to do away with like, oh, the kids are sleeping, we got 2 minutes, let's see if we can have sex. That goes out the window for patients right now. Like, it's not, I tell them, like, you're not a $2 beer, you're a $500 bottle of wine. You have to take your time to go through the whole event. It's like, okay, let's have some time. Let's actually get you good and ready before anything goes into anything, right? So, and I tell them that sex is not the act of penetration. It's the whole day. It's the text messages and the talks and the I love yous and the affection that gets you ready to get into that state. Is that like, the kids are sleeping, we got 2 minutes. Like, that is not. That is going to cause significant pain. I usually recommend them using some organic lubricants like Crisco or coconut oil, like organic cooking, frying coconut oil. It glides forever. It's not going to change the pH of their vagina. So there's a lot of different things that we can do. A lot of the times I tell them to buy pelvic wands or vaginal dilators, but not to use them until they've gone to pelvic floor physical therapy and or to go to pelvic floor physical therapy and start using them with them. And they can do both hot and cold therapy, but they have to have somebody, they have to have that guidance from pelvic floor PT.
Yeah. Yeah, I agree, because I've had so many patients like try it on their own, they hurt themselves and they get discouraged. So that's the opposite of what we want for our patients. And then totally agree with the exercise is so important, right? But again, is any of the exercise causing the pain? Let's find exercise that's not causing pain. Or do they like the exercise that we're even recommending? Because if they don't like it, then they're not going to do it. So I do find that figuring out what they like and modifying that exercise for them can be really, really helpful. And I totally agree with the sexual activity. You need to get the bathtub going with the organic bubbles, things that won't irritate, things that will calm you, or heating pad, or doing some stretches together, something to get you in the mood for that $500 bottle of wine, for sure.
Yeah,
Yeah.
exactly.
Yeah, and then is the
It's very
pizza.
eye-opening. It's very eye-opening when after surgery, I talk, because I draw it out for patients, right? So I basically come on and I say, okay, so this is the vagina, this is the urosacral, this is where they're located. Even though I'm drawing it for them and I'm basically using a whole bunch of colors, which anybody that's seen me can tell you, like, hey, I use so many colors on this page so that they can differentiate what the endo is, what the endometrium, myometrium, pelvic floor muscles, uterosacral, vulvar cavernosus, like everything, right? So we talk about all these different things, but then it's such an I think it hits usually the male partners, right? And when they see, oh, this is for uterosacral, and you see the difference between this one that's nice and pink, and you see this one that's all destroyed and scarred. So obviously, if something is hitting this particular thing, you see how red and inflamed it is. So imagine if every time you had sex, somebody would flick one of your gonads. That's what she feels when she has deep penetration, right? So we talk to them about like the O nut or things to limit penetration, to be more patient with their partners. And actually I feel proud when I tell them and I'm explaining it to them and they're like, so I was not helping. I'm like, no, you weren't. You have to be more patient. But I've seen some wonderful partners with some of my patients that are like, no, we're like, and they're really commendable guys that are like, or guys or girls that are like, okay, like, yes, this, I felt it, so we modified things so that she's not feeling sad or she's not feeling that she can't contribute. But I've heard some horrible stories in which patients are like, have such horrible pain with periods, but and every time we have sex, I'm in pain for a couple of days, but I'm sad because I'm afraid that he's gonna leave me or he's gonna go and do something else. So then they would rather tolerate that pain, so because of the fear that the partners are gonna leave them. So imagine what has to go through the mind of a poor woman that's in pain. That she'd rather be in pain for a couple of days just so that she can satisfy her partner because she's afraid of him leaving. So the psychological state that you have to be as a woman, like in order to allow something like that to happen, it's disastrous, right? So that's why we have to do, like, if when we miss it, these are the things that can significantly affect the or have a negative self-image for the patient herself,
Right.
right?
Yeah.
So that's
So
why we have to do what we do.
yep, and education, as you're saying, is so important because they really don't. Most people don't understand the depth in which we have to, treat the patients and the lifestyle, the mental health part of it. That's so important. And you mentioned earlier about the pizza, like they could be lactose intolerant, gluten intolerant. So really addressing the body as a whole and the person, the people as a whole is so important. And that's why we work so well together, because we're on the same page.
We are.
We are. um, yeah, so thank you so much. Where can patients or providers find you? And like website, social media?
So I am on Instagram and on Facebook. I have a page in each. So in Instagram is at Dr. Endometriosis, Dr. Endometriosis, which actually also sounds Dominican Republic
I know,
Endometriosis.
I was gonna say.
But so it's kind of it was a friend of mine actually. He's a plastic surgeon. He's like, you should get this name. So it means both things, Dr. Endometriosis and Dominican Republic Endometriosis, right?
Seizing
So yeah, I'm like, okay, that sounds like a good idea. It's just like, just do it. Trust me. And it's been wonderful. And I'm glad that we're doing well. We're educating. We're putting a lot of work, talking to a lot of people um, on Instagram and just promoting good content, good surgeons in different countries. There's a lot of patients that don't have the possibility to come and see us in the US. So I also I've talked to other surgeons in specific countries like, hey, like maybe your patient can't come to the US because of whatever visa reasons or something, then you have other resources in other countries and which really great surgeons that you can go and see them as well. And then people that I already know that are doing a really, really good job. Because unfortunately, it's hard. So for example, something that happened for me recently, it's like I no longer tell patients who do I have surgery with. Why? Because I've gotten burned a couple of times. Like, oh, you can go see this doctor that's on the NOOC list in X, Y, and Z town. And then they go have some surgery, some stuff gets left behind because it's complex, and they're put on Orlissa, Lupron, or a whole bunch of other medications. And then their pain does not improve. And I was like, oh, okay. I'm sorry.
Yeah.
So, and then I sometimes operate on them, and I find, like, I operated on a patient yesterday that had surgery with an endo specialist, not even less than a year ago. And she had so much endometriosis, so much endo there. She had so much endo. It's so I don't even know. I don't want to fathom that it was that they just left it behind. That's what I want to think. But in 10 months, you're not supposed to have so much endometriosis return. Deep pockets, deep stuff, ovaries are stuck together. You're like, okay. So it's time for me now to like go see XYZ. So that's why I sent patients to the doctor. Go to Nancy's book, go to, and then look at surgeons in your area if you want to, but you would have to do your research. You have to talk, you have surgery, you want to have surgery with X, Y, and Z, talk to 10 or 15 patients that they had surgery. Who had surgery with this doctor? Talk to me. Give it to me honestly, right? So that you can make your own decisions, because I'm no longer recommending anybody.
Yeah.
I can't. Like, I've been
that
burnt too many times. So I'm done. I tried being good and saying, oh, that's fine. You don't have to come. But now it's like, it's a different story.
Yeah. Yeah, it's a tough place because you want to help them, but you just don't know. I had a patient the other day that came to me. We suspect endo, we're not sure, so you may be hearing from her. But yeah, she actually had gone to my mentor like a couple decades ago, and it didn't go so well. And I'm like, huh, you just never know. You never know. And referring can be a challenge because you get concerned about what should happen. So I hear you.
Yeah. I mean, but one of the things that we do is we just learn to be brutally honest and transparent with patients.
Yeah.
Which is why, like, I give them around 30 pictures minimum of their surgery, right? 10 to 30 pictures, like, or sometimes 60 pictures of their surgeries, because I literally take a picture before and after. So there's a lesion of endometriosis. This is the after. So you can see how it looked before we touched it and after, and how big the lesion was, right? Or how big of a halo and what's remaining. Because a lot of the time patients are like, oh, I had surgery 3 years later, they found a whole bunch of endo. Like, I don't know. Look at, and I give them a USB copy of their video if they want it, right? Yeah. So that they know and they can see, hey, that lesion that you had there wasn't here in the first surgery, right? So that's why
can calm themselves down too. Like, okay, I had it,
yeah.
but it's gone. So
well, I mean, yeah. So we do tell them. So I never tell them that their endo is gone. It's like we can get it as close to a cure as possible,
right?
But there's always disease that can be left behind that you can't see the day of surgery, which is one of my biggest pet peeves. Is like there's a lot of patients that before surgery they put them on Lupron or Lissa or Bifimbri or any other of these medications that can be quite dangerous. It can have significant side effects without even knowing if they have the actual disease that these medications are supposed to be treating.
Right.
So it's like, oh, I think you have endometriosis. Let me give you this really expensive medication that and let's see if it works. And it has significant side effects.
Right.
And if it works, great. But if it doesn't work, fine, we'll do surgery. But that's worse, because if it doesn't work and they're on the medication, then you get taken back to the operating room with a medication that's meant to decrease the inflammation that endometriosis causes. So you would only be able to really truly see the old, very clear lesions. But the new early lesions of endometriosis may be completely flat or disappeared, or you may not see them expressed that much. So a lot of the times we see tissue that looks red or inflamed, and guess what's going to happen? It's going to come out. Right? Because I don't know, but that pathology also has to look at it, right? So if you're giving a patient medication that's meant to hide the disease, it's actually a lot harder for the pathologist to say, hey, this spot that you removed was endometriosis here now. So it doesn't make any sense. Like, it's like going into surgery with your hands in your eyes.
Yeah. It's like we were.
Yeah.
Well, thank you so much for doing this this wonderful podcast. And again, everyone, this is Dr. Jose Eugenio from the Center for Endometriosis Care in Atlanta. And I hope to see you again at the Endo Summit, or maybe we'll meet in DR. Y habla español con
That'd be
ustedes.
great. That'd be great. You know what? Next time I go there, I'll let you know. I may go there in August. So if that's the case, like, there is. I'd love for you to go there and talk to some people about pelvic floor PT stuff. So hopefully, I have a dream to do an endometriosis summit in the Caribbean at one point. I just have to convince Sally to go a little bit lower than Florida.
Cao bien.
Okay.
All right.
Okay.
All right. Great to see you.
Likewise. Have a beautiful rest of your day.
You too. Take care.
Bye-bye.
Bye-bye.